So, thank you for this fantastic presentation. We are coming to the next presentation of Justin Carrard, and it's really a pleasure to introduce his talk here at the podium. And I have to say, and it's really a pity that he's now working here in Lausanne, responsible for the sport, youth and health unit at the Swiss Olympic Medical Center, but he's as well a consultant. And it's a pity because we worked 10 years together in the past, and he was in Basel University, but still there's a cooperation. And Justin, you are not only a good researcher in that regard, but you are kind of sport medicine politician. You bring people together. You founded the youth SEMS, and I think it's a junior SEMS, and it's fantastic what you are doing for sports medicine, and I'm really looking forward to your talk.
Hi, everyone. Thank you, Arno, for the nice presentation. It's a bit impressive here. It's a bit big. So my talk is from fatigue to overtraining, beyond the dichotomy of structure and function. And actually, when Boris called me a couple of months ago and asked me to speak of fatigue and overtraining, I directly say yes, because I love this topic. I'm passionate about the topic of overtraining, and it's very interesting, I think. But then he say, whoa, not too fast. You have to respect the topic of the conference, which is structure and function. It's not only about overtraining. And to be honest, it was quite difficult. I didn't really know how to combine both structure, function, overtraining. So I started by reading the editorial, the warm-up that Boris wrote in the BGSM. And the title was Structure and Function, Parallels Between Sports Medicine and Artistic Currents in the 20th Century. So I learned that Cubism is representative of structure, and Bauhaus is representative of the function. But to be honest, art is not really my strength, so it didn't help me a lot. Sorry, Boris. I had to read further. And I found this article published in Advances in Physiology Education. And we are told that every physical object is made of components that are giving a particular 3D structure. And this biological objects, are interacting with each other to give rise to the function. And they say that the structure is determining the function. And they give the example of the cardiac conduction, for example. If you know the cardiac anatomy, the cardiac anatomy is giving the function to the heart. So this spoke to me, and I say, yeah, well, that I agree with. And they add that changes in function can also change the structure. And here again, they use the example of the heart. So if you do exercise, you are going to remodel your heart. So I think we can all agree that the structure shapes the function, but the function can modify the structure. And this is true at the macroscopic level, here, for example, on the level of the knee, but this is also true at the microscopic level. And here I took the example of the hemoglobin, which is the protein transporting oxygen in the blood. And so the function of this protein is given by the 3D structure. And depending on the function, for example, if you're going to exercise, the active tissue, the muscle, are going to become warmer and acidic, and it's going to change the 3D structure of the hemoglobin to ease the release of oxygen on the active tissue. So I guess the question is, what do we know about fatigue and overtraining in terms of structure and function? So first we need to speak of fatigue, and fatigue is actually a continuum, starting with acute fatigue. So we all know acute fatigue. After a single training session, we are a bit tired. We're going to rest for 20, 30 hours, and then it's going to be better. And little by little, we're going to progress and to improve. The second stage is the one of functional overreaching. And here, that's the typical case of a training camp. You go with your squad for 2 weeks somewhere. You train more than usual because you don't have to care about working or your job. And little by little, you're going to accumulate fatigue and the performance capacity is going to decrease. But eventually, you go back to your normal life and you have to take care of your children, your wife, your job, and you don't have enough time to train every day. And you're going to recover, and little by little, you're going to improve. And this is what we name the super compensation. So both stages are actually physiological, they are fine, and they are part of a normal training schedule. The issue is starting with the third stage, which is the one of non-functional overreaching. So here, basically, we push too long or too much. And even after a time of recovery, the baseline, so the performance curve is only going to reach the baseline again. So basically, it tells that you invested a lot of time and energy into training for nothing. So it's kind of a useless state. And the last one is the one of overtraining syndrome. And overtraining syndrome is basically the same, but even if you rest for months, sometimes even years, you're not going to recover. And both stages are part of the pathology, so they are not part of the normal training program and should be avoided. And I will be using the icon of the Bauhaus and Cubism that I found on Wikipedia to indicate if we are more into the function or into the structure of something. So here, clearly, we are into the function of the body. It brings me to the definition of overtraining syndrome. Basically, it's an accumulation of training and or non-training related stress over a long time that result in a reduction in performance capacity. And we can have, but it's not mandatory, to have signs and symptoms of physiological and psychological maladaptation to training. And as I said, the recovery is going to take long, and long is weeks, months, sometimes years. So this brings me to the overtraining syndrome pathophysiology, which is quite difficult. I try to simplify it here. So basically, we have a disbalance between stress and recovery over a long time. And this is going to induce alteration in the brain with a reduction in in the level of serotonin, an increase in dopamine, and a reduction in noradrenaline. It's going to impact the hypothalamus and the pituitary gland and lead to a reduction in prolactin, ACTH, and growth hormone secretion, especially as a response to exercise. At the same time, there is a dominance of the parasympathetic over the sympathetic nervous system. And this is a bit how the overtraining syndrome is explained from a central fatigue perspective. But there is also the peripheral hypothesis behind overtraining syndrome, which is basically turning around muscle. As we know, muscle is a contracting organ, but it's also an endocrine organ, secreting stuff called myokine. It's part of the inflammation process. And we do know that glycogen depletion play a role in fatigue accumulation as well. It has been observed that overtrained athletes have mitochondria that are not working very well. And here, I would say we are both in the function and in the structure or in the mechanistic of overtraining, because we understand some part of the pathophysiology, but not all of it. So what do we do when we have a patient that is fatigued or we have the suspicion of overtraining syndrome? So this is the algorithm that was published in 2013 in the last consensus statement on overtraining syndrome. So the first question is there a drop in performance? If the reply is no, there is no overtraining syndrome by definition. The second question is, do the person do enough? And here it's very subjective. It might be 10 hours, but sometimes 10 hours is just the right amount of training for someone. And we need to take the stress outside training as well. Then we need the duration of symptoms for a minimum of 4 weeks. So if you see a patient and he has been complaining for a 3-week episode of fatigue, it might become an overtraining syndrome, but it's not the case yet. And at the end, we need to see if something else can explain the symptoms. And usually when I assess fatigue in an athlete, I'm using the Olympic rings. And here today, for a copyright reason, I'm presenting you the first Olympic squares. So in the first Olympic square, I have this is the square of performance. As I said, we need a reduction in performance capacity. The second one is the one of stressor. So we need to take a detailed history of the stressor in the life of the person. The third one is the one of recovery. Is the person having a day of break per week, or is the person training every day? What about sleep? Is there any other recovery strategy in place or not? The fourth square is the one of nutrition. And here I'm thinking mainly of the relative energy deficiency in sports syndrome. So we need to make sure that the person is eating enough in terms of calorie and protein. And the last one is the one of mental health. Nowadays, we have good tools that were published by the IOC to detect a mental health issue. Same, I'm using the Olympic rings or square here for the differential diagnosis. So the first one is the one of deficiencies and hematology issue, iron deficiency, vitamin deficiency. In the second square, I put all the infections. Usually, there is a reduction in the immune system if you have overtraining syndrome. So athletes tend to have weird disease like the toxoplasmosis, for example. The third one is the one of metabolic disease. I think in a young athlete, especially a female athlete, it's good to take a TSH at least once to make sure that it's not a hypothyroidism. The fourth one is the one of immunological disease. As an internal medicine specialist, I have to say that lupus is never a wrong reply. It can mimic many things. Same for the celiac disease. And the celiac disease is especially important if you have an iron deficiency, because we do know that the prevalence of celiac disease is 1%, but if you have an iron deficiency, it's 10%. So in that case, it's good to look for the celiac disease. And in the last square, it's more like the sports and exercise medicine, specific diagnostic, overtraining, RETs, ALO, etc. And I put harassment and abuse, which is a very important topic, obviously. So at the end of the day, you will tell your patient, well, I think you have overtraining syndrome, but to be honest, I'm not sure because it's a diagnosis of exclusion. And what we now have to say, it's, well, I think you have overtraining syndrome, but I'm not sure. And by the way, it might be RETs as well. Because we do know that there is a kind of overlap between overtraining syndrome and RETs, both in terms of the continuum. I would say the difference is for RETs, it's a disbalance between input and output in terms of calories, while overtraining syndrome is more disbalanced in terms of recovery and stress. But you can have both. You can train too much and not recover enough, and don't cover your caloric or protein intake. So I said that it's a diagnosis of exclusion, but there are a few tools that have been published and are apparently useful to diagnose overtraining syndrome. And I would like to speak of one of them, which is the TOP test. The TOP test was published by a colleague from Brussels. It means the training optimization test. And basically, it contained the 2-bout exercise protocol. So they do 2 cardiopulmonary exercise testing with a break of 4 hours in between. And they take blood before and after each exercise test. And they demonstrated that overtrained athletes have a blunted ACTH, prolactin, and growth hormone response after the second exercise test compared to healthy athlete and athlete with non-functional overreaching. So I would say we know quite a lot about the function. We know a bit about the structure, but not a lot. And no, I'm a bit biased because I will present you a bit my own research, and I'm very interested into metabolomics. So if you think of biology, you need to have the picture of a chain in your mind, starting with the genome up to the phenome. And the phenome is who we are, and the genome is made of genes, as Yanis told us, and describes what may happen in the body. But there are many different intermediate steps, and sometimes what may happen does not happen. And this is why I'm very interested in the metabolome, which is made of metabolites. These are small molecules, including lipids, and they describe what has happened in the body. So it's much closer to the end result, and this is why, in my own opinion, but I guess we can discuss this, it is more relevant from a clinical point of view. What is interesting is that the metabolome is influenced both by the genome, the transcriptome, the proteome, but also by the environment. So what are we doing, how much sport are we doing, what kind of food are we eating, but also the internal environment, which is the bacteria that are living in our guts. So the metabolome is also very, very diverse compared to the proteome or the genome. We have many, many chemical species that have been described. And this is very nice to give you a kind of fingerprint, an individual fingerprint of each person. If we specifically look at the small molecules that we have in our blood, most of them are actually lipids, about 70%. And as it's written, lipids do not only have roles in fuel and energy metabolism, but they are also signaling molecules. And I think this is where it starts to get very, very interesting in terms of overtraining, fatigue, and recovery. And basically, there are two ways to acquire the metabolome. We call it metabolomics. So metabolomics is the science or the technique used to acquire the metabolome. And we can do either a targeted or untargeted metabolome. Untargeted is more when you don't have a hypothesis and you want to generate a hypothesis. So you're going to acquire as many metabolites as possible. And the targeted approach is more when you want to test a specific family of molecules. And now there is a third approach that has been using more and more. It's a bit in between, where you can acquire a lot of metabolites. When I say a lot, it's about, like, for example, 1,000 metabolites in a targeted way. And the big advantage is that you have an absolute quantification. So you can cross-compare your result with other paper, which is difficult but very possible, but very tricky is the untargeted approach. So what we are doing at the moment is we are trying to apply metabolomics to this 2-bout exercise protocol to acquire a metabolic fingerprinting of athlete with overtraining syndrome, non-functional overreaching, and healthy athlete of functional overreaching. And this is a collaboration with a group of Romain Moisen from Brussels, who developed this 2-bout exercise protocol. So to summarize, I would say that structure shapes the function, but the function can reshape the structure. I would say that overtraining syndrome is mainly understood from a functional point of view, and we don't know a lot about the structure and the mechanism that are underlying fatigue and overtraining in sports. And I think that post-genomics is a powerful way to bridge this gap. Well, thank you very much.